There are huge success things in research. Advocacy going a long way already. But even though we have modern treatments, even though reimbursement might be possible in many places, still it doesn't end up in the hands of the people with diabetes.
Right.
And the reason is that we need to educate the healthcare professionals, not only the doctors, because doctors have rarely a lot of time, and much of the care is done by the allied health professionals. So the whole diabetes team need to be educated about how these new therapies can be used. And this is not easy because for 100 years, the diabetes teams have dealt with insulin. And insulin was the only thing. And knowing how to use insulin wisely was they knew and what they related to their people with diabetes that were in their care. But now they have to understand immunology, the autoimmune disease. They have a new group of potential drugs that could be used. They have adjunct therapy to insulin so that insulin plus something else.
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
Thank you. Welcome to the Global Diabetes Insights. So this is what we've been doing. So I had the honor of delving into this amazing podcast session with one of the most respected and remarkable people in diabetes field, Professor Thomas Danne, and I'll allow him to briefly introduce himself to the audience, if you may.
I'm a pediatric diabetologist by training. I did 40 years treating children with diabetes. And after my retirement from the hospital, I'm now the Chief Medical Officer of Breakthrough T1D, which maybe a couple of you know as JDRF, Juvenile Diabetes Foundation, but we really believe it's about T1D, type 1 diabetes.
Wow, wonderful. Thank you so much. And we're excited to have you. And thank you so much for taking your time to be here.
My pleasure.
To take the question that we have that the global diabetes community might have to ask you, but they might not have the chance to see you because, you're a busy person and doing a lot of work. They've been in this field for about 4 decades. That says a lot. So now we just want to learn from you. Maybe the first question that we have is one of the architects of modern pediatric diabetes care. What key shifts in care and technology have you witnessed that were once only a theory in early, if you may take it off?
Well, when I really started way back then in 1981, starting with a thesis on pediatric diabetes, I compared porcine insulin with human insulin in the treatment of diabetes. That was with finger pricks, and something like continuous glucose monitoring was rocket science to me, something that will not happen. Now that I left clinical care, my last relations with families were parents who said, with this automated insulin delivery device, we can sleep again at night. Whatever the glucose is in the evening, it's perfect in the morning. And this is such an incredible improvement. I really feel that it's accelerating. It's getting quicker and quicker. It's like a logarithmic curve, So it started slowly. We had spaghetti curves of glucose, didn't know what it were. Then we had the first automated pumps in laptops, which nobody could wear. And now it's getting faster and faster that we are achieving devices that reduce the burden of type 1 diabetes.
Wow, thank you so much for sharing that overview with us, and even the young healthcare professionals that have been looking to learn from you. We look forward to this. How can I get to that? How can I do that? You've witnessed many things have happened. People have done a lot. I think the future is bright with what is happening while we look for a cure. But now the focus is really to try and improve care for people living with type 1 diabetes. And you've been immensely involved in this thing. So thank you so much for your work and your passion, your dedication into this. for your
But it
whole
also comes back to my heart. It's a labor of love, so to speak, because it's a mutual thing. The people with diabetes have given me also quite a lot. It's not a one-sided thing.
next question that we have. He has been at the forefront of research. Now he left clinic work into automated insulin delivery with the things that we now have, with the advances we have seen. How close do you think we are to achieving a fully automated, patient-friendly artificial pancreas, and what roadblocks remain?
Obviously, in my new role in Breakthrough T1D, we really are looking to, of course, do the research to do things even better than they are now, but also to look at all those things that make it difficult for people around the world to have access to these breakthroughs or those new types of therapies, those things that really make a difference. And in the end, to improve lives of those living with type 1 diabetes before finally we have a cure of the disease. And I hope very much that I will be still alive when we have a cure. And as a pediatrician, I'm always an optimist. So I really believe this is possible. I really believe we'll be able, with cellular solutions, to completely change the way we are treating type 1 diabetes today.
Right.
But this should not let us forget that the people with diabetes live today.
Right.
And we really have to make them reduce the burden and have the best possible treatment in the different areas of the world, which is still a lot to do.
A lot to do. Yes, thank you so much for saying that. And one of the points that was even made at this conference where people say people with diabetes would also want to wake up one day without worrying about diabetes, about their care. Me as a person living with type 1 diabetes myself, if you don't have everything that you need, if you don't have all the options closer to you, like in the part of the world where we come from, where we're struggling just to get hold of these CGMs, and even for basic necessities, people still struggle to get them. I don't know if these device manufacturers are to think of coming to Africa or other low to middle income countries. Do they think like, are we going to make a profit of this? Because we are in business. Maybe let's just see how things will go. All these things that we are doing, all these things that have happened, it's a matter of just trying to improve the quality of care for people living with this condition while we wait for it. In our lifetime, I hope to see it too. Maybe we're close. Yes, of course, I've heard other doctors say, since when I began in clinic 40 years ago, I hoped to see a cure in 5 years. Probably they're getting hopeless. Thank you so much. You still have that hope. You hope to see it while you're still alive.
Absolutely.
So I guess, we are moving.
And I'm not that young anymore, so yeah.
I hope you're really cool, right? So wonderful. At least now we have novel therapies that can delay the onset of diabetes to those that are at risk.
Absolutely.
So which is something else. And now I think the shift needs to be focused, and then people need to come together, work together again.
We need a movement.
Yes, we need a movement. Like that has been the theme for Breakthrough T1D on all the sessions that I've been hearing. When Sanjay was saying about it, yes, join the movement. What is that about the movement? If you can tell us briefly about it.
Well, I guess everybody with T1D has to understand that together with the treatment team and together with all the other advocates, we all have one goal: to make the life with type 1 diabetes different from how it is today.
One goal.
That one day we will say, yes, type 1 diabetes was something I also had once. But it will take steps.
Yes.
And everybody plays a role in these steps to the final goal, whether it is in research, from very basic science to clinical adoption, whether it is advocacy, that we are lobbying politicians, other stakeholders, make them understand what type 1 diabetes is, which also means that we need to submit data. So for example, we have the type 1 diabetes index. It's something where you can actually model what in your area, in your country, if we would have access to this, that, or the other thing, what the impact would be, how many healthy years of life for a couple of people in your country would be saved, would be improved. And so we're looking for, giving a scientific basis to everyone, that you could go to your stakeholders and say, listen, I've looked here in the type 1 diabetes index. For example, in the neighboring country, it looks better. Why is that the case? Let's discuss what we can do different. How can we be as good? For example, Sweden is always used as an example where diabetes care, type 1 diabetes care is particularly good, simply because they have very good data. They have a very good registry, and they're very ambitious. They have the most ambitious goals. To take examples like that and say, how can we do the same, what I have learned in other areas in where I live, and we want to help people to do that.
Wow, beautiful. Thank you for saying it like that with such great passion. And now that you brought up the subject to do with sweet, and me as a person who come from the low to middle income countries, we talk about good registries, data, which T1D index is trying to push. We do not have accurate statistics, and usually the numbers we see are just estimates, because even our government, they don't know how many people are living with diabetes, and maybe they don't even take the level. And we need to prioritize this because they don't really understand the impact. Maybe they know, but they ignore it. It's not important to them. It's not a priority to them. So you, as a person who has led international activities, initiatives like SWEET, Inodia, how do you envision transforming pediatric diabetes care in under-resourced settings where advanced technology isn't always accessible?
The history of SWEET was that initially we went to the European Parliament with children that size.
Wow.
From different European countries, saying those children have type 1 diabetes. We showed the first model of insulin pumps to the politicians and say, well, there are lots of differences between European countries. We need to change that. So what we need is data to show what is going on, to give you a basis to make decisions. We got some money so that we could start in 7 countries. Now, today, it's no longer a European project. It's a worldwide registry, 150 centers worldwide on every continent.
Right.
We have more than 100,000 people with diabetes who are captured with their longitudinal clinical data, so that we can say, okay, in this center, for example, the 300 patients who are treated there, they have improved their diabetes care because pumps were introduced, or sensors were introduced, or multiple daily injections were introduced, modern insulins, things like that. So really to have data, look at the different things that have happened over the time, which impact it was. And again, it's benchmarking what's all about. Benchmarking means I compare my data within our center. How are we doing? Are we improving? Is it getting worse? But we also compare between centers. And what we found out, for example, is how important it is to have targets, to have ambitious targets, to have the whole team agree on these targets. What do we want to achieve? What's the next step? Where do we want to be in 1 year? I guess that's an example that with this international collaboration, we really can make a difference, because when we look at those centers who participated in the SWEET registry for 10 years, all of the centers really were able to improve. It's really the importance of data, and we are trying to reproduce this kind of movement also on an advocacy part, that we're using this type 1 diabetes index to deliver data, best possible data, work together to get the best data also, for example, in Africa, or on numbers, that how many people are there, what's the situation, what type of treatment do they have, and then simulate if we would change something here, this is what would be the result in 10 years from now. And this is a language that politicians and stakeholders understand, and so we hope very much to give you actionable data, that you know the numbers, and you will be able to change the numbers if you have those numbers in your hand.
Wow. I don't know what to thank you for that instrumental work. This is a new initiative that you started. Other centers wanted to be part of it. We need to come up together. We need to compare this. How are we managing things? If we can improve, because the idea is really to impact on the people that you're trying to serve, so that if Germany is doing it, if people in Portugal are doing it, then why can't we? Where are we missing? Where are the gaps? So that we try to close them.
And it's a movement. It's working together, exchanging ideas, exchanging best practices, and that's what will bring us further.
Definitely. Thank you so much for that. Focusing on your involvement and your contribution in your research in insulins, pumps, glucose sensors. I've been attending conferences, and always, whenever you share, we want to know more, we want to learn more. This is amazing, because these are the people that are really involved in these things. They're not just studying of things that they're reading books, they're actually involved in research. What is the next big innovation in insulin therapy that excites you the most? Why?
To be quite honest, it's kind of a continuum. Yes, the automated insulin delivery, where sensors and insulin pumps are connected, and we have an algorithm that the sensor data is used to kind of guide the insulin delivery from the pump, is a great step forward. However, diabetes technology can have a failure. You still have infusion set failures. You might have a risk of DKA. Still can have a hypoglycemia, although the risk is lower. You might have skin problems because of the sensor or the pump. Right. So in the end of the day, this is not a cure.
Right.
It will help to get much better control, much better outcomes. And one could probably say already now, many people are able with such a device to reach glycemic control, which makes it very unlikely that they have severe late complications of diabetes.
Wow.
But we have to understand that type 1 diabetes is not a metabolic disease. It is an autoimmune disease, meaning that the immune system is the issue. Right. For example, if I compare it to another autoimmune disease, rheumatology, in the old days, we have treated it only with painkillers. If you had rheuma, you took painkillers. Now there are treatments, there are drugs, tablets that simply make this autoimmune disease to really change it so that the pain is no longer there because the underlying disease has been treated. And this will also be possible in type 1 diabetes. It's a completely new way of thinking that we say, okay, if we're able to detect this type 1 diabetes early enough, we will maybe be able to stop this autoimmune disease before the insulin producing cells are destroyed.
Right.
And so this is why we have a big call for in the different countries to do this early detection, because that's also something we can do. We know that antibodies are in the blood earlier before type 1 diabetes really occurs. We usually say many get type 1 diabetes actually in adulthood, the majority still child and adolescence. But the antibodies of those who develop type 1 diabetes in adolescence, 80% are actually already detectable in the first 2 years of life.
Right.
So we have a lot of time to intervene if we have those new treatments, and there's the first treatment as regulatory approval in a couple of countries, and this is just the beginning.
Right.
So this is one thing where I think a lot of things are happening, but we need actually this knowledge for those who have long-standing type 1 diabetes, where this is too late.
Right.
But we are now able to produce insulin-producing cells out of so-called stem cells in abundance. It's no longer necessary to have cadaveric islets or cells from people who are donating, usually people that are deceased. We now have lots of insulin-producing cells, and we are just looking into ways how we can transplant them in people with type 1 diabetes. We will need the information of those disease-modifying drugs to keep those cells alive, because the autoimmune disease is still there. So if I replenish the insulin-producing cells without stopping the autoimmune attack, it will still destroy those cells again. But there are more and more modern treatments to kind of very meticulously change the immune system, or that they don't just be cells, and we're working on this because this will then be a new way beyond insulin where we can probably treat type 1 diabetes.
I wish we could just stop the recording here, but we have other questions. Wow, thank you so much, Professor. Thank you so much. This means a lot. Even to the people that are still doing research, they're going to watch this. They'll be really encouraged. What is it like as a reminder to say, this is what we're trying to do. We are trying to achieve this, and how should we move forward? Also, we need to consider where we are coming from and like where are our mistakes. Then if we can do something, if people can actually be cured for diabetes, top. If these antibodies can actually be detected, if we have the resources that are necessary to do that. Now there are novel therapies that can delay the onset for the moment, because that's what we're talking about. That'll be okay. That's a game changer. That's another thing. If I was diagnosed with diabetes at 18 years old, and if those antibodies were present, maybe I had 1 or 2 at about 5 years old, maybe something could have happened. At 5 years, probably nothing was showing. I was perfectly okay because they were just antibodies. And the beta cells were finally destroyed. But thank you so much for that thought-provoking conversation that you have just given us here. Moving forward now, this is for motivation and for encouragement. Young healthcare professional, you also been mentored, and now you're mentoring other people. Now that you left clinic, so many people are still coming to you. Well, Prof, what can we do? How can we do this? So how do you view the role of mentorship in keeping pediatric diabetology at the cutting edge of medicine and innovation?
First of all, I think it is important to motivate people and to make it clear to them that working in this field of type 1 diabetes or diabetes in children is worthwhile, because it's one of the most exciting areas in medicine. I believe we at our organization Breakthrough T1D say it's not a question if there is going to be a cure. It's only the question when.
When.
So you need 2 things in order to make that when earlier.
Right.
Number 1, you need clever people, young, dedicated people who want to be part of this. Of course, you need funding. It's, in the end of the day, a money game, how quick it is going to be. So we are talking about philanthropists around the world that will help us on this way. I mean, it's a big organization of more than 600 people at Breakthrough T1D who work daily to get this funding ready, to support the research and support young people in particular to become part of this movement. So I just want to tell the people that, for example, through ISPAD, there are now 1,800 people here in Lisbon coming together, discussing what is new children and adolescents with diabetes. Every one of them, I'm sure, will leave with new ideas and go to their home country and try to get that message across that this is a very important time. And we have Breakthrough T1D together with ISPAD is supporting science schools, both for the allied health professionals as well as for physicians, where I also started, and I met those people that are still in ISPAD very often. It's the start of their medical career. Those are friendships for life. I think it's so important for a happy life to have people that have the same mindset as yourself.
Definitely. Thank you so much. And in those 1,800 people here in Lisbon, about 50 people or more are people living with diabetes, which is good. Now that the door has been opened, now they can also be part of these things. And also to say that, yes, even for me as a person living with diabetes, I've been invited alongside Emma Stratman. We are both part of the ISPAD 2025 Conference Science Committee.
Excellent.
To give our overview, to say our insights as well as people living with diabetes. What do we want to see being discussed? What should they be prioritized? So I think now the world is changing. We need to be working together. Yes, of course, you might be the best, you might be a master, but you also need people supporting you, working with you, collaboration.
I couldn't agree more. And I think the saying, nothing about us without us, is a very good saying and very, very important, because in the end of the day, whatever the researchers, the clinicians are doing, it has to be focused to the people with diabetes, otherwise it's no good. And so we always have to sit on the table together to make those decisions.
Wonderful. Thank you so much, Professor. So as someone who is deeply involved in clinical trials, what would you say are the critical steps in translating these cutting-edge research findings into practical everyday care for children living with diabetes?
This is a very good question. Clearly, Breakthrough T1D never had a doctor in the executive team. The reason is 1/3 of those people working in Breakthrough T1D are people with diabetes. So it was clear at some point now that there are huge success things in research. Advocacy going a long way already. But even though we have modern treatments, even though reimbursement might be possible in many places, still it doesn't end up in the hands of the people with diabetes. And the reason is that we need to educate the healthcare professionals, not only the doctors, because doctors have rarely a lot of time, and much of the care is done by the allied health professionals. So the whole diabetes team need to be educated about how these new therapies can be used. And this is not easy, because for 100 years, the diabetes teams have dealt with insulin, and insulin was the only thing, and knowing how to use insulin wisely was they knew and what they related to their people with diabetes that were in their care. But now they have to understand immunology, the autoimmune disease. They have a new group of potential drugs that could be used. They have adjunct therapy to insulin, so that insulin plus something else will be used. And already on the horizon, they have to know how to transplant cells, how to keep those cells when they're infused in the portal vein or wherever in a pouch, how to keep those cells alive so that they're functioning well, that they're producing insulin, maybe that they have to have an infusion of cells or whatever. The whole picture is changing. In my mind, not too distant future. And there's a lot of learnings, and we have to think of now, how do these centers that are treating people with type 1 diabetes around the world, how will they look in 10 years from now? And how do we adapt that to the different places? Certainly the type 1 diabetes center in Africa will look different from the one in the US and different from the one in Asia. But we have now the time to discuss that, to find out what are the needs, the local needs. how do the systems work, what type of training is necessary, how to make that work. And so we have research, we have advocacy, and we also have medical affairs to make all this, what we are finding in research, to end up in the hands of the people with diabetes.
Well, thank you so much. I cannot thank you enough. And because of our time, I'll just make this be our last question. This is the talk of the moment now. AI, diabetes technology, automated insulin delivery, biotechnology that are advancing rapidly. What ethical considerations should guide the development and implementation of these technologies, particularly when it comes to children?
Well, we want to harmonize care around the world. That was is the motto of SWEET, the Diabetes Registry, that we are comparing data to have equal care around the world for all children with diabetes. And this looks very, very steep, looks like something that cannot be accomplished. I disagree. I think really we are in a time where the acceleration of new therapies is reaching a point where we really can start thinking of how can we unlock access also on a global scale, and this has been done in many other diseases already. Just to look at what we were able to do with immunization and infectious diseases. In the end of the day, type 1 diabetes is an autoimmune disease. It's a very clearly defined disease. So I'm confident that these advances will hopefully be able to help children around the world in the not too distant future.
Wonderful. Thank you. Well said. Brilliant. What would be your last words to our audience?
My wish is that this will happen as quick as possible. I'm just leaving for a meeting with people who are willing to donate, who have donated quite a lot of money for the research for breakthrough T1D before, and discuss, just like we have today, discuss with them what can we do better, what should we do to have more funding for the so important research, advocacy, and medical affairs in type 1 diabetes, to make the mission of Breakthrough T1D to have care and cure for children, adolescents, and adults, the whole time span of people with type 1 diabetes, really to improve it and finally find a cure as quickly as possible.
Beautiful. Thank you so much to Professor Thomas Danne for the amazing conversation that we had. I had the opportunity to ask anything and everything, and I hope that you'll be inspired, encouraged, and motivated, educated if you should. Keep your eyes watching and join the movement. As he said, Breakthrough T1D is trying to do some good, trying to do research, funding research, and to do amazing stuff. So yeah, looking forward to more and stay tuned for more. Thank you so much, Professor.
Pleasure.
That was amazing.
Thank you.